So we are live.
Okay. Good afternoon, everybody, and welcome to the module 11. This will be the last module, and we have saved the best for the last. So this is regarding how to actually go ahead and set up a myopia control clinic. We have a long list of speakers and experts who can guide you, tell you about how to truly start a practice of myopia control. So I have with me our today's moderator, Dr. Stuti and Dr. Nyuti. Before they start the session, I would like to put a word of thanks to Namrata ma'am for giving us this opportunity to work on myopia control program. These were all 11 modules. It has been a long journey, but very fruitful and very satisfying journey. It has been almost 2 months, and she has been helping all around. So thank you so much, ma'am. And this would be the last session for myopia control program, myopia control certification course by AIUS. So I think I would give the mic to Dr. Stuti and Dr. Nyuti.
Good afternoon, everyone. Thank you, AIOS, Namrata Sharma Madam and Jethani Sir for this kind opportunity to be a part of this myopia management series. And indeed, this module has been well elaborately planned, and ophthalmologists across all specialities are likely to benefit from this because we are going to continue seeing the increasing trend in the incidence and prevalence of myopia. I also thank and pass on my regards to all the panelists who've taken their time out to be a part of this program in the middle of their day, and they share their valuable experience. Now, we all agree that myopia management is the need of the hour. And now, with all the modules which we have done and covered, we are laden with all the knowledge and information about the control strategies. Now, let us go to the most important part of it, which is how to plan our setting. And there we can integrate our clinical expertise along with a financially sustainable and suitable model dedicated for myopia. I invite Dr. Reena Bhatt, Madam, from PGI Rohtak, to please elaborate on how do we plan a myopia control clinic.
Good afternoon, everyone. Just share. Are my slides visible?
Yes.
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 So I would like to congratulate, first of all, Dr. Jitendra Chithani and Dr. Namrata Sharma ma'am for organizing this AIO certification course on myopia management. And it's a huge success, and I think it has helped everyone to update their knowledge. So with those words, myopia management, as we all know, this is the fastest growing specialty nowadays. And my talk is basically for all eye care practitioners who usually see 10 to 30% of myopic patients in their OPD, but do not have a separate clinic at present and are thinking about having one, or are at the beginner level and want to take the game to the next stage. The components of my talk will be why open a myopia clinic, roadmap for myopia clinic, pitfalls to avoid when opening a myopia practice. In terms of prevalence and number, WHO and BHPI, they have given us the data that by 2050, it's predicted that 50% of the population will be myopic and 10% will develop high myopia. High myopia has serious health implications. Each additional diopter of myopia increases the risk of retinal detachment, myopic maculopathy. Moreover, children are becoming myopic at younger ages with faster and longer progression. Clinical trials have already established the success of the interventions in controlling myopia progression by 40 to 60%. So the key to establish a myopia clinic would be to provide myopia management so that the chances of reducing the development of high myopia. Very few clinics are there which offer a structured and dedicated myopia management services. So this will also differentiate your practice from others. So these are the patients who are going to be engaged for long periods of time, and that will hence cause revenue generation. Continuity of care usually fosters generational loyalty among the parents and the patients. And we should all remember that today myopia management is not optional. It is an obligation for all eye care practitioners. It's a duty of care. This is a practical roadmap for myopia clinic. First of all, before starting the clinic, when you're planning for one, you need to acquire knowledge, practice your skills, be competent, set your clinical protocols, acquire the equipment and the infrastructure which you need, training of the staff, and designation of duties as required, completion of all the needed documents. Consider your pricing structure, design a marketing strategy, reporting, and monitoring. So there are a lot of electronic resources available, and you can attend the CE meetings to update your knowledge. This is one of the simple questionnaire which is available on the myopia profile. In this, which you need to just put the age of the child, and you need to mention whether the child is myopic or not. Then history of the parental myopia, how many hours does the child spend outdoors, how many hours of near work. On the basis of all this information, the software gives you actually what is the risk of developing myopia in a child, and also offers some suggestion. I think this is a very useful tool which can be used for a pre-visit triage. Like you can send this questionnaire to most of your patients so that the parents become armed with information and they're already sensitized. So it's very easy to convince them for all the interventions for management. The other is PREMO, which is a predicting myopia onset and progression. It's an evidence-based risk indicator for eye care practitioners. This has been designed by the NICER research group. It has two parts. The first part, in the first part, you can see it tells you about the risk of the child becoming myopic. So you need to know the age of the child, the parental history of myopia, cyclopegic refractive error, and the exit length. It has two tables. One is for 6 to 8-year-old children. The other is for 9 to 10-year-old child. And in case you don't have the cyclopegic readings or the exit length measurements, then you can use the keratometric readings also. It gives you at the end of all the information, it gives you the risk score. And on the basis of this risk score, it also suggests the modifications. Then you have the second part of this, which is the risk of developing, risk of progression of myopia if a child is myopic after 6 years of age. For this also, you need the age of the child and also the annual progression of the spherical equivalent. Then it gives you a risk score on the basis of your clinical judgment and the risk score. You can it tells you about the recall intervals and the management. Other is the online BSBI calculator, which is a video shows about it. It's quite scientific, and you see, you have to put information about the ethnicity, the age of the child, and also the baseline refractive error. It tells you how much the progression of myopia can be controlled in terms of the spherical equivalent or the axial length elongation on the basis of the intervention which you have chosen. It has two graphs. One is a red graph, which is without management. Other you see is a green graph with management. So when you choose a intervention, like in this orthokeratology, there's not enough data. That is why it has come up with this. But when you choose an intervention, it tells you how much reduction in the progress of myopia you can get. Another thing which they've recently added is it also tells you about the risk of non-myopic children or the pre-myopes becoming myopic. So in this, you have to see put the baseline refractive error again. So you see the more hyperopic reserve the child is, the lower is the risk of the child becoming myopic. This is a useful tool for counseling because when you explain the parents in terms of diopters or millimeter, it's difficult to understand. But with the use of graphs, it's very simple for them to understand the importance of the interventions which we are going to offer in our clinic. So you have to set your standard practice patterns. Your SOPs have to be in place. This is what we follow. For this, you first need to identify your patients. So they are going to be the recently diagnosed myopes or can be pre-myopes or kids who are at high risk with parental myopia, and also the patients on follow-up at your center, your old trusted patients. So when you have identified, you enroll the patients in your clinic. For this, you can select one day as your fixed clinic day. And later on, when your OPD rises, you can always keep it 2 days a week. And you can enroll all these patients for a WhatsApp group also. Then remember that communication is the key to myopia management. You need to spend time and engage the parents, the patients in long conversations because you need to do the profiling of your patients. So for this, we have designed a questionnaire. You can make your own questionnaire, which will include details about the visual acuity, the history of parental myopia. You need to know whether your child is currently on glasses or contact lens, and what is his lifestyle, his reading habits, how many hours of outdoor play does he do, and is he enrolled in some kind of sports, his sleep habits, everything. Once you're aware of that, you go to a basic myopia workup. I'm not going into the details. The next speaker is going to take this. Just a word that it includes a comprehensive eye examination, visual acuity, cycloplegic refraction has to be done. If the child is school going, you can call him for subjective refraction, anterior and posterior segment examination. A few myopia related battery of tests, like the excellent measurement is mandatory. A peripheral refraction, because it tells you about how much peripheral hyperopic defocus the patient has. You have to do the accommodative and the base binocular vision test to diagnose the accommodative lag and esophoria. And other imaging and scans, if needed, like corneal topography, I would say if you see a young child with very high myopia, you need to rule out whether it's a curvatural myopia or axial myopia, then it helps. And you might come across high myopes in your practice. So for them, ultrawide field imaging is really useful to spot the peripheral degenerations, and OCT macula helps you to diagnose myopic maculopathy. So you need to equip your clinic with the right tools. See, whenever you're adding a specialty, there is some investment upfront. But for a basic myopia practice, this is all what you need. So the cost is not too high. You just need to, for the cycloplegic refraction, peripheral refraction, and dynamic MEM, you just need a streak retinoscope. And along with that, you have to conduct a few accommodative tests and binocular vision tests. So basic equipment. You can just have us to start with a manual A scan, because excellent measurement has to be taken. So the cost is not much. But later on, you can keep adding the technology and equipment in a stepwise manner. Of course, that will depend upon the volume of patients you see and the ROI. And to start with, I would say the most powerful tool is the optical biometer, because it will give you the excellent measurements, the keratometry readings, the lens thickness, the pupil diameter, everything which you need for a myopia workup. And you can identify the pre-myopes, and you can also illustrate this to the parents. So to add on, a corneal topographer you would need if you are thinking about starting with the dispensing ortho-K lenses or dual focus contact lenses, then you would need corneal topographer. So most of the companies in the market now, they have come up with 3-in-1 inbuilt technology, like the Oculus has introduced Myopia Master, or Top One has come with one additional corneal topographer inbuilt. So it all depends on what suits you. And in case you already have a retina practice, or you have done an audit and you see that you're seeing a lot of high myopes also, then it's useful to invest on technology like ultra-wide field imaging or the OCT. So team on board is the face of your practice. They are the first point of contact of the parents. So a regular training of your team regarding the protocols which you're going to follow is mandatory. And also the entire team has to speak one clinical language, so for which you can always script your FAQs. And you can pick one key member as a myopic coordinator, and that person will arrange the scheduling of the patients, and also the recalls, the queries, all that can be done by that person. Coming to counseling, as like I said, myopic management needs a lot of chair time per patient. So if you're running a busy clinic, you can train a counselor, and they have to do the complete documentation of the records, because nowadays it's important to take informed consent also, which will include the age of the patient, the baseline refractive error, the excellent, the progression of myopia, what interventions you started, how was the compliance, everything should be mentioned. And then they need to educate the parents about the lifestyle modifications, the treatment or compliance, and the follow-up appointment. You have to decide what are the therapies which you are going to offer in your clinic. For that will depend on the availability, the practicality, and obviously on the evidence. Availability and practicality, I mean to say, like if you are thinking of starting the ortho-K lenses also, or the dual focus or the idea of contact lenses, you would need the support of a lab consultants also, materials, infrastructure, so that can be added on a next stage. And also, you have to learn how to customize these interventions per patient. And for that, you would need the baseline data of the patient and the sessions with the parents. And other thing which you can do is that at present, if you're seeing myopic patients, you can always review records of these patients, and you can audit the effectiveness of the treatment you are getting at present. And then you can make necessary changes when you start the clinic. We all know that myopia management is not covered by insurance. And so about the fee structure, I would say that it will depend on a lot of factors like the chair time and then multiple visits per year and the infrastructure, the manpower, equipment. So either you can have special packages also for those families who are getting a lot of patients, or for those trusted patients who have been with you for a long time. Whatever you decide, at the end, it's very important that you maintain the transparency whenever you're communicating the fee structure with the parents to maintain that trust. Last but not the least, market your myopia practice. Even with clinical excellence and the proper systems in place, patients won't come unless they know about your expertise and the services. So proud and loud, get the word out there. And for this, you can use the in-office posters and the brochures. You can prepare myopia journals, which have all the record of the patients. The awareness videos can be running in your OPD. You can celebrate Myopia Awareness Week. And also you can have a dedicated website page, or you can have a mascot or a logo can be designed. You can do internal branding. Social media can be used because it's to create an impact, because it's used by all the users of eye care. And you can have engagement with the schools, the pediatricians, and the parents groups who can get patients for you. There are a few pitfalls to avoid when you're opening a myopia practice. Inconsistent communication with your team within your team leads to confusion and mistrust. Families may experience sticker shock if the pricing is not introduced gradually and clearly. Relying on a single modality limits your capabilities to individualize the care. Without structured reminders, families can drop out of care, and many practitioners they hesitate. Remember, the delaying means missed opportunities for early intervention. So the key takeaways: myopia epidemic is real. Your confidence and authority begins with strong knowledge. Optical biometry and cyclorefraction, they are the core tools. Your team on board are your communication bridge with their parents. Families will invest when they understand the value. Patients won't come unless they know about your services. A successful myopia management clinic requires not only it requires a lot of systems and not just enthusiasm. These are the guidelines which we usually follow. Thank you for your patient hearing.
Thank you, Dr. Reena, for this elaborate talk. And we have great set of panelists here with us today who will share their experience and guide all of us across different setups, be it a private practitioner or a group practice setting. We have Dr. Meenakshi Swaminathan, man who needs no introduction. She's a senior pediatric ophthalmologist and has been the head of medical education at Shankar Nethralaya. And currently she's into private practice. Madam, we welcome you. Dr. Amit Solanki, sir, he's a private practitioner and is a director of Shanti Eye Care. He's an alumni of Arvind Eye Hospital and is an expert cataract and glaucoma expert. Thank you for joining in, sir. We have Dr. Deepak Garg, sir, who is the director at 3D Eye Solutions in Mumbai. He's a trained pediatric ophthalmologist from Shankar Nethralaya and has been running myopia clinics in Mumbai. We welcome you, sir. Dr. Amit Mohan, sir, who is a pediatric ophthalmologist trained at Arvind Eye Hospital and was a consultant at Sadhguru Netra Chikitsalaya and has multiple publications on myopia management and its progression. Welcome, sir. And we have Mr. Rupam, who is the head of operations for Zeiss and also manages the Zeiss Vision Centers and myopia clinics in India. So we have all of them to help us today. And as Madam has already elaborated on how to go about it, what are the thoughts? Could I request Dr. Meenakshi, Madam, to please give us an opinion on how do we go about it? Do all of us need a dedicated pediatric setup, or we can make it a part of our routine practice? And when do you think it is wise to keep a day aside for myopia clinic?
Thank you, Dr. Stuti. And before I launch into anything, I first want to congratulate Jitendra and such a successful module, such a timely series of modules, immensely useful, because we all know myopes don't come just to us, and myopes go to all ophthalmologists and even practicing optometrists. So it's essential that everybody has good knowledge. In fact, my first one, when I was a panelist, Jitendra, I actually took notes, and went over it, and fantastic content. So I congratulate you and Dr. Namrata for this excellent idea.
That's what I was going to say. That all credit goes to Dr. Namrata. Definitely. To have faith in us and start this whole program.
Absolutely. And I also should say, excellent talk, Dr. Reena. Reena is the wife of Chekitan, who was my first thesis student, so very special to me. And then what greater pride to see Dr. Deepak Garg, one of my senior most fellows, who is doing a fantastic job in Mumbai. So I have to say these things. These are
Ma'am, we
very
all are your
important.
students, madam. You
I
are
know, I
teacher
know.
of teacher.
Yes,
You
yes,
cannot
yes.
take it away from us.
Absolutely.
You can't give it only to Deepak and
Okay.
Reena and Stuti.
No, Deepak has a special privilege of having stood next to me and gotten scolded. So that's a special relationship. Anyway, these are very important relationships for me. So I wanted to say that first. So I just wanted to say I have the unique opportunity of having been in an institution and started a myopia clinic way back 10 years ago, and then coming to a group practice where I was the only ophthalmologist with access to nothing except me and my retinoscope. And then going to a group practice now where we have limited number of instrumentation, but the optometrist and the team is not tuned to myopia or myopia management. So I have different scenarios I've been a part of. From that, I will only say one thing. Great if you can start off a myopia clinic right away, but it's important to start the documentation right from your first patient, whether you have access to these things or not. So whatever data you want to collect, which Reena very beautifully elaborated, maybe in another clinic. When I was by myself, the optical biometry was in somebody else's clinic. The orthoptics was in somebody else's clinic because I didn't have space or equipment availability. So it's important to collect the data and have access to all these instrumentations while you slowly build your myopia clinic. That's the number one. And second question that you asked very quickly, I'd like to answer. Do you need a dedicated day for myopia? I think that is, I don't think that is practical. Of course, if you're a very busy practitioner, yes, but myopes, you may get a myope as a new walk-in patient. So what do? You can't send them off and say, no, you have to come on Friday because that is my myopia clinic day. So I don't think that's a practical solution. I think you have to build in myopia workup into your, outpatient flow. And I am old-fashioned, so I don't like to use the word marketing. So I'd like to call it public education. Okay, and so I public health and public education. And I again and again say the best place to start is with your kids' school, where you are as a parent are almost always welcome. So you can start by talking to the kids, talking to the parents, because a lot of the intervention, talking to the school authorities, please don't cut the PT period because exams are coming. Okay, please don't ask the children to sit inside the class and have their lunch. Make sure there is good lighting in the classrooms at the blackboard or the smartboard and where the child is seated. These are all things that they will listen to because you are a parent and a professional. So I would say start your public education there and then build it up.
Thank you, ma'am. And Dr. Deepak, sir, if I could ask you, so if somebody is to start a clinic, what in your opinion is that they should reflect upon? Should they see the number of patients that they are seeing, or should it be the equipments that they should focus on, or it is training a counselor or a dedicated pediatric optometrist? What do you think is very important for them?
Thank you, Stuti, and thank you for having me. See, in private practice, I think it's difficult to plan every single thing that we ideally would need. But out of all the things you mentioned, for me, in my private practice, a pediatric optometrist would probably be the most important because they will be doing the workups, they will be doing the retinos. Fortunately or unfortunately, we as practicing ophthalmologists, we do less and less of retinos. But apart from that, it's very difficult to say, oh, I will not start a myopia clinic because I don't have XYZ equipment. That's not going to come soon. It takes a long time. I've been in practice for 17 years, and today I can say I may have some equipment that I need. But even 5 years ago, it would have been a challenge for me. And therefore, I will go by what Dr. Meenakshi said, that at least what we can do is to start writing everything down, to start following a process. And I think the process should be defined, like Dr. Reena mentioned in the beginning. And once the process is defined, as and when we upgrade, we can add those equipments to our practices. But we need to, I think, even if you consider the topic of today, which is, setting up a myopia clinic, I think even from a financial perspective, it's good to start a clinic. And over time, it will build up into something that you are happy about.
Thank you, sir. And a quick question to Dr. Mohan, sir. What do you think? Can we run a myopia clinic by not doing axial length, or is it necessary to do axial lengths at every visit?
I think it is very important. I am at present time working at the Sankarai Hospital, Jaipur. Here we are running the myopia clinic, and in the myopia clinics, there should be something different from the other clinics so that you can attract your patients or parents for the myopia evaluation. So combined optical biometer, which are axial length, as well as it shows the in the follow-up visits, like we are using Topcon Maya machines in which they at every visits it measures the axial lengths and they are showing the graph, and we can show these graphs to the parents for the active intervention. So I think the axial length measurement is must for the running the myopia clinic.
Thank you, sir. And Dr. Solanki, sir, what kind of education materials do you use? Do you go back to the old school pamphlets, or you are updating to the WhatsApp groups or sending reminders? What is it that you practice, sir?
See, basically at present, like I would say more focusing on cataract and refractive. I do not have any dedicated myopia control clinic.
So
But
when
yes,
patients come to you, it is more of a
yeah.
verbal counseling that you go in for.
Yeah, so we do a lot of like awareness, like, because we see Dr. Jethani sir was our inspiration and he was our senior. So we always used to follow his teachings. Like I remember, I'm not buttering you, Dr. Jethani sir, but this is fact that in MNJ while doing MS also, we used to just copy his notes. Same thing we followed what he used to do at Arvind also. So here, while starting my private practice also, before starting, in fact, I visited his hospital. I stayed there in Baroda for one night. I spent one entire day how he works in the private practice. So unfortunately, I could not start a dedicated myopia control clinic. But yes, we are following the main thing Dr. Meenakshi ma'am and Dr. Deepak said. We are documenting everything. Like we are measuring so we have taken a one baby step towards starting a dedicated myopia clinic. And as far as the education, awareness, marketing is concerned, so we have started doing the school screening programs. And soon, like we will take help of the social media reels and all these things also. But the first baby step we have started taking.
So the key message, I think, in this segment is that we should start by documenting and then move on to acquiring equipments, but the basis being a good cycloplegic retinoscopy, maybe a trained pediatric optometrist. So let us now move on to the next session. Thank you all the panelists for your expert opinions. And we now move on to the next one.
So like we saw how to open a myopia clinic. So now let's go through what instrumentation and equipments are needed to start a myopia clinic in our daily practice. So Dr. Riddhi Bhatt will take you through the presentation on instrumentation and equipments required to start a myopia clinic. Over to Dr. Riddhi. Dr. Riddhi, you are not audible. Dr. Riddhi?
Till the time Dr. Riddhi joins in, probably I can pitch in a few comments that I thought
Sure,
would
sir.
be beneficial for everyone over here. So as I've been watching this myopia and this myopia space over a period of time. First of all, thank you, Dr. Jethani, for this opportunity, and Namrata ma'am for this. I think I've got messages from many optometrists across India as well who has been benefited from here.
Sorry.
You are, ma'am. You are.
Yeah. And is my screen visible?
Not yet.
No, not yet.
We'll just start here. By the time you share your presentation, Mr. Rupam, you were giving
Yeah,
us some
sorry.
input.
Sorry, I interrupted.
Yeah, no problem. By the time you're sharing your screen, maybe you could just give us a quick input, please.
Yes, so what I was telling was that even if you don't have a retinoscope with you yet, you can always start off by telling all the patients who come into your clinic about your myopia clinic. Because most of us don't know when to get our kids' eyes tested normally. So everybody who walks into your clinic has a trust and faith in you. So everybody who walks into your clinic should know that you do a kid's eye testing or at least a eye screening. Because the first one who identifies that there is a problem with my kid's eyes gets my entire faith and trust on them, right? Even if they don't treat my kid, right? So just a quick screening is also very important for you to set the patient trust. That's the thing. And we have ready-made parents in our clinic, right? We have ready-made grandparents in our clinic. So if we can just tell them that we do kids eye screening, and the right time to get the kids eye screening is at just when they're born, and then after 3, 5, and every year of their life. I think that's going to be very helpful, because most of us don't know when to take our kids for eye screening. That's one part that I wanted to just say, that even if you don't treat, you can at least tell, because the doctor who tells the first is always remembered by the parents, and they will come back to you for other services. Thank you.
Thank you for the comment, Mr. Rupam. That was indeed an important one, the baseline screening that we have. Dr. Riddhi, we request you to please share your presentation.
Yeah, I'm sharing my screen. Is it visible?
Yes.
Yes,
Yes, it is visible.
Good afternoon. I'm Dr. Riddhi. I'm practicing pediatric ophthalmologist at Ahmedabad. And at the outset, I would like to thank AIOS and especially Dr. Namrata for setting up this wonderful module of myopia control. I would like to thank Dr. Jethani, who has been, who kind of made my interest go in myopia, and I'm taking baby steps based on what he has taught me. So thank you, Dr. Jethani, and all my mentors at LBPI from whom I've learned the basics, and all the expert panelists and presenters. So when we start with how to plan a myopia clinic, the first question which we normally face is, can we practice myopia in our existing setup, or do we need a separate space? While the separate space is definitely more pediatric friendly and it saves a lot of time, as we have set protocols and instruments in place, it's also better to have a separate day, so it becomes easier to talk to patients, and there is a lot of group discussion when the patients are waiting. And also equipments, optical biometers, if you're planning on rent, you can ask them to come and on a particular day, so that helps if you have adequate number of patients and a separate space and separate day. That definitely helps. But then for a smaller setup like me, who's just starting out, I think what is important is that saves patient another visit, and I think in the initial practice that really helps going a long way. So there are three parts which I would like to discuss. First is the documentation and risk stratification, which is very important to know which patients we are actually planning to manage. The diagnostic equipment, whatever basic equipments we need when we are starting, we are planning to control myopia, like establish a myopia control clinic. And the third aspect is the management of myopia and what it would entail, especially a pharmacy and an optical, which helps us in managing myopia. So whenever a new patient walks in, like I'm talking about a smaller setup, if it's a group practice, you have a retina person, you have a corneal instruments, everything is easy. But if it's just a single practitioner and when a new patient walks in, I think the first steps are very important, that you give a good visual acuity and diffraction with age appropriate vision charts. You do a good binocular vision assessment, IOP, and a cycloplegic refraction with a retinoscopy with a good cycloplagia is a must. Many people, they do a dilated autoref, but it is not a substitute for a retinoscopy. And ideally, we should also, as pediatric ophthalmologists, if we don't have a pediatric optometrist, we should learn to do retinoscopy, because there's a lot of difference in the autoref values and the retinoscopy values. So what I practice is, when the parents are waiting outside in the waiting area, they're just waiting for the cycloplegic refraction, I have a small questionnaire where they are supposed to mention the age and sex of the child, obviously, because males, there's a difference in the male and female child also. the parental myopia, whether one parent is affected or both parents are affected, and what was the age and magnitude of refractive error in the parents, because that is also directly correlates with the myopic progression risk in the child. Also, sibling myopia is important to be documented because apart from the genetic factors, there are environmental factors as well. So the age and the refractive error of the sibling is also equally important. It is good to discuss the lifestyle of the child. What is the daily routine of the child? Which class is he studying in? Which school he goes to? And even the board, because there are differences. Recently, I've realized there are different board entails different amount of screen time and the near work. So what homework duration the child does, what is the screen time when the child is watching TV versus laptop versus phone, and what is the physical activity the child engages himself, and what kind of sports does he play. At times I've seen the parents telling me that okay, they are interested in sports, but what they're playing is actually indoor games, so that doesn't count. So outdoor activity time is the actual parameter which we need. So these are some detailed questionnaires which are also available online, and sometimes I give it to the parents, just to think over something when they are at home. So now that I have done a good cycloplegic refraction, retinoscopy with cycloplegia, as I said, is a must. It's important to give correct glasses in the first visit. If I'm not satisfied, I usually call the child for PMT, not though as a routine, but if I find there's too much of a difference and I'm not sure, it's better to call the patient for PMT rather than do either undercorrection or an overcorrection. Also, slit lamp and a good fundus examination by a good indirect ophthalmic examination, not just a direct ophthalmoscope by some, not only the central, the periphery is equally important, and that is the whole point of myopia control, that we want to prevent the myopia complications. So now that I have given the glasses, given the correct refraction, and I've advised follow-up. In case by the questionnaire I feel that the risk of progression is high, I do optical biometry in the first visit. Why optical biometers are important is because we are targeting axial myopia. These are the patients who actually need treatment. So it helps us determine on follow whether there is true progression about 0.2 to more than 0.2 to 0.3 mm per year is called as progression. So sometimes we find myopia has progressed, but the axial length is stable. In such cases, we have other parameters to look for corneal and lenticular myopia. So if we have an optical biometer at our own place, that it is good to do it in the first visit so that we have a good follow-up of how the patient is proceeding. So either we can have a dedicated optical biometer for myopia, or even in bigger institutes where there are optical biometer being used for cataract purposes, they are usually swept source based, while the dedicated myopia optical biometers, which I'll be discussing later, are mainly partial equivalence interferometry based. So this is how I document everything in the first visit, and I maintain a chart because I subsequently keep on adding as per the visuals of the patients. The spherical equivalent, the axial length, the average K, AL by CR ratio, which is very important, and the screen time in hours. So now that the child has come up, I call the child after 2 months with the new glasses, or if the child is being referred from somewhere else with a documented progression for myopia control, I normally do a quick over refraction to see whether there is any change in the refractive error, and I do a cover test for distance and near. Cover test for near, exophoria for near, the patient has poor convergence, myopes usually have convergence insufficiency, or if the patient has esophoria for near, that gives me an idea whether they might have an accommodative lag. And these are the other binocular vision tests which I normally do. So why is it important to assess the binocular vision anomalies? Because there's a comparative study from India, from South India. So I have found that low myopes, they do have convergence insufficiency, while high myopes have a convergence as well as accommodative insufficiency. So this dysfunction contributes to myopia progression, and that helps us to give an idea what kind of myopia control strategy we can use in the patient. Even non-strabismic binocular vision anomalies are also very common. So I do a quick stereopsis with random dot distance and near using Polaroid glasses, a worth 4 dot test red green glasses with a near torch, and a distance using the vision system, and a AC by A ratio using the heterophoria and the gradient method. NPC and NPA are really important to be documented with the correct optical correction. That is why at the first visit, usually it's just the correct glasses which are normally given, and the risk factors which are discussed with the patient, or the optical biometry. The rest of most of the investigations are done on the follow-up because they need to be wearing the correct glasses. So NPC, we have NPC and NPA, we use the RAF ruler. which has a rest, it rests on the cheek, and there are 4 kind of targets which can be given. The dot is used for the convergence NPC. So we have to start pushing from distance to near slowly, and the point where the patient starts seeing double, that is the break point. And again, we take the target from near to distance, and where they recover, that is the recovery point. Now, more than 10 centimeter, if it is there, it suggests a poor convergence. NPA is also measured uniocularly and binocularly, and if an RAF is not available, we can always do a push-up method where we can measure the point where there is nearest point where there is a sustained blur. For that, we need to give the near target as per the best corrected near visual acuity of the patient. So this RAF ruler, as I said, there are 4 targets: N5, N8, N10, and N12. So whatever best corrected refractive near vision is there, depending on that, the nearest point where the patient starts reporting a sustained blur. Because if we are planning to start atropine, it would recede the NPA even further. I also check for a quick range of accommodation, accommodative facility using flippers, and fusional amplitudes using vergets. At times when I'm not able to do it, I usually have a pediatric optometrist who comes and does a dedicated workup. If at all I find that there are some accommodation or convergence anomalies. Dynamic retinoscopy to find a lag of accommodation is something I do myself. It is very important with the patient because most of the myopes, they exhibit greater accommodative lag than the emmetropes. When the eye under accommodates, the image is focused behind the retina, which acts as a signal for the eye to elongate. And closer working distance increase the demand on the eye's focus, leading to a higher sustained lags. And children with higher accommodative lag, they often experience faster myopia progression, and so interventions like progressive addition lenses or multifocal contact lenses are more suitable for them to reduce the lag. So while the patient is wearing the correct distance, these are usually dynamic retinoscopy cards which are available to be mounted on the Welch Ellen retinoscope. And this patient is asked to read these cards at 40 centimeters while we do a quick retinoscopy, and lenses are put to neutralize the width movement. Any lag of more than 0.75 to 0.1 is suggestive of accommodative lag. It is also important to do a peripheral refraction with the patient wearing correct subjective correction in the glasses, because relative peripheral hyperopia is contributing to the mesial elongation. So we check for the retinoscopy in nasal and temporal retina about 20 to 30 degrees. So any hyperopia or to the tune of 0.5 to 0.75 is a precursor of axial elongation. So these are good candidates for peripheral defocus glasses. So there are open autorefractors which are available. They are not very widely used now though. So what I normally do is a peripheral retinoscopy using a peripheral refraction aid. Obviously the patient is wearing the correct optical correction. This video is thanks to Dr. Jethani for providing me with this video. So this is how the retinoscope is mounted onto the device, the peripheral refraction aid. So there are 2 arms which helps us to do retinoscopy in the 20 to 30 degrees periphery on the nasal side and on the temporal side.
Used this particular device mainly to, we have used two videos here. One is from the top view, and right now we are asking him to look on this particular side. See, we are asking him to look on his left side, and we are recording the refraction. It is pretty simple actually. Once you tell the patient to look on this particular side, and if you get a width reading, suppose if you're getting a width reading, this patient doesn't have glasses, but if he have glasses, you tell him to use his glasses and try to look on the peripheral side.
Now, we'll talk about optical biometers which are available. I personally feel it is must if I'm practicing myopia. It is must to get an axial length reading. So one is the Myopia Master by Oculus, which gives keratometry axial length and also has an added advantage of providing topography. So in steep corneas and keratoconus screening, and even in orthokeratology lens fitting, it helps to have a topographer. Maya by Topcon is another one. These optical biometers have usually their ingrained axial length charts also. So they do measure axial length and monitor the progression of myopia and compare measurements with the growth curves for axial length. So this is the example of an chart by Maya Topcon. So it shows how the it is supposed to proceed if the patient continues in the same manner, and if we plan any intervention, what is the expected myopic endpoint of that patient, and we can serially document the progression. Again, so the above line, it demonstrates where the patient would have landed up if the patient progresses in the way the patient is progressing, and the blue line usually shows what by intervention, how we can reduce the myopia outcome. The Maya by Topcon has also an additional advantage of dry assessment tools. The third one is a pristine OBM 12 by Remedio. It has an advantage of being an auto-refractor plus an ocular biometer. So someone who is just starting out his practice, it does save, it is like easier on the pocket. And it has an automated quick 3D eye tracking. So it only takes the reading when the reading is quite accurate, and so it is pretty child friendly.
Dr. Ridit's last 2 minutes. Can you just
I'm just about. So the
Dr. Riddhi, your voice is not. Can you, Dr. Riddhi?
I think there are some network issues with her. So in the meantime, could we ask?
And
yeah, okay, she's back.
Okay. So this is the last slide. The advanced imaging is useful for monitoring treatment.
The slide is not seen, Dr. Riddhi. Can you just share your presentation?
Okay. Is it visible now?
No.
Just a minute. Yeah. Okay, the macular OCT is important to monitor subfoveal choroidal thickness, because as the eye elongates, the sclera and the choroid stretch. So a thinner choroid is associated with a greater risk of developing myopia, maculopathy, and choroidal neovascularization. Any subfoveal choroidal thickness decreases by about 13 microns per 1 diopter increase in myopia and 23 microns per 1 mm of axial length. And these are the biomarkers for myopia and maculopathy. So it is good to, if your institute supports it, it is good to have a subfoveal choroidal thickness. It also helps to titrate myopia management, because treatment by red light therapy and lenses have been used to increase the myopia thickness. Not 0.01% atropine, but higher doses of atropine have been shown to increase the choroidal thickness. We either need an ED OCT or a swept source OCT. And also again, wide field imaging, which helps to screen retinal periphery. This is just a few analyses. They have shown to have myopia control intervention on choroidal thickness. Again, pupillometry is given by some biometers, which helps in determining the mesopic pupil size, especially patients we are planning to put on low dose atropine, because 0.05% does have shown increase in pupil size, which causes photophobia and near blur. In Indians, it's not that of a problem, but in Western population, they have been forced to use photochromic glasses and bifocal glasses. Also, iberometry and tear film assessment, as the patient is planning to use chronic topical medication, or we are planning to use contact lens. So few tips that I have learned is give importance to the disease. Like I normally give special tags to the case, or special day, as someone else mentioned. So we can give special tags that this is a myopia case. So it helps impress the parents that okay, this is actually a problem with the child, which I need to be careful about. And to ensure compliance with the patient, there are cloud devices, which Dr. Jitendra, I think, talked before, to check the screen time and the near work of the child. And also, I dispatch bottles of LD depending on the follow-up that I'm advising. So, and the patient is asked to bring back the empty bottles. Thank you.
Thank you, Dr. Riddhi, for the wonderful presentation. Now, I'd like to ask a question to Dr. Meenakshi. Like when a private practitioner is starting a myopia clinic, what are the basic instruments we should start for a myopia clinic other than the refraction?
So, so if you have, so I think first of all, one has to sit down and calculate what would be the expenses. And if you can introduce the instrumentation in a phased manner. So, and also along with that, you train yourself also. For example, things like peripheral refraction or doing orthoptic evaluation is not our routine for all of us. It's not in our comfort zone. So, either if you are lucky enough to have a really good pediatric optometrist and orthoptist, you can trust them to do some of these. Otherwise, you may have to learn it yourself. But I think an optical biometer is number one. I think we all agree on that because a lot of our treatment is based on the axial length. Following the axial length, even more than following the cycloplegic refraction. So in initial years, I used to think the cycloplegic auto-ref is very important. Now, I'll be honest with you. After a few patients where I used cyclopentolate, I had some reactions in the clinic, and so I have switched to homatropin. And with homatropin and some, when the child looks at the auto-ref, you get values all over the place. So I still think our refraction is very, very important. So I'm coming to the point of whether an refractometer is a must. I am not very sure. I'm a little skeptical about it. But I think keratometer. So optical biometer, keratometer. And then as a second phase, you definitely introduce the peripheral refraction and orthoptics. But before you do anything, have your data collection, your software for myopia patients ready from the first patient. I think that is so important, and nobody better than Jetani actually to comment about it because he's a researcher in the core, and that really that passion drives his clinical work, and I think that's so important to keep track of, to have a protocol and to keep track of data. Thank you.
Thank you, ma'am. I would like to ask the question to Dr. Deepak, sir. Sir, so when you started your myopia clinic back 5 years, so what axial length machine did you have? You used the optical or the normal what we use in cataract? So which axial length machine did you start with as for a myopia clinic?
We already had an optical biometer, so it was easier for us. But I agree that if you have to have one equipment apart from what you need for a basic eye clinic, the first will be a biometer to measure the axial length. The second could be, luckily the peripheral refraction, etc., that Dr. Jethani has kind of provided all of us. Those things are not expensive, so those things can be acquired easily. And the next big thing will be, of course, a topography, which will be a significant cost.
Okay, thank you, sir. So now let's move to the next presentation.
Can we just a minute? Can we ask Mr. Rupam what all equipments are part of a Zeiss myopia clinic? Like if you're establishing a myopia clinic, what are the list of equipments that you sort of tell the doctor that these things should be there purely from a market point of view? What equipments are necessary and how does the protocol goes around there?
Yeah, absolutely, sir. Thank you for that. And the instruments which are very much required for a myopia clinic is, of course, an axial length biometer. That's non-negotiable. And if it comes with autoref, it is very, very important because the parents perceives autoref as a fancy instrument that my kids' eyes get tested by a computerized device, though retinoscope remains the most important thing. Plus, what is also very important for a dispensing part for a kid is that you have a proper centration device in your clinic. That's something which is very, very important. And what we always recommend for the myopia clinic is that keep your dispensing area separate for kids. Even if it is a contact lenses or a spectacle, keep it separate so that your patient knows that these are actually helping them in a medical treatment and they can't go out and walk into an optical store and have it. If it looks like a normal optical store, you are giving me an option as a parent that I can still go and check in, other optical stores. But if it is a separate area, it's very, very important. And apart from all the instrumentation, what I found to be most important is a good counselor. Uh, Parents will not ask questions to a doctor at all. They have all the questions that they go and ask the counselor. So that is something which is very important as well. So probably to everything what everybody has said, probably a centration device is very, very important, and a separate dispensing zone for kids is also one of the very important thing to retain your patients in your practice for a very long time that you're looking for.
And
Thank you,
now
Dr.
on this, I would ask Jethani sir, how do you think it is financially sustainable for the general ophthalmologist? If whatever we do, as per what Mr. Rupam has said, how do we decide is it a financially sustainable model for us or not? What is your experience now?
Yeah, I think so. If we talk about finance part, the finances, if we talk purely about return of investment, the bulk of bulk of the equipment, as Dr. Amit is there, but as Deepak also said that you already have an optical biometer with you. So most of the people, I'm not saying, I'm not generalizing it, but most of the people would have a sound optical biometer in place. However, if you are beginning your myopia control clinic, now they have those combined equipments like Myopia Master. And if we go towards the cheaper equipment, there are OBM 12 by Remedio, and even the Hewitts has come up with a combined auto refractor with keratometer with the optical biometer. They are not swept source optical biometers, so they cannot be really used for very advanced cataract, but they can be used with clear lenses or a little bit of cataract here and there, and they have done some work on that. But so those equipments can help you at least in the beginning, because then you don't need it removes the keratometer, autoref, and this thing biometer from your this practice, so that reduces your budget. Second thing is they do have some intelligent softwares where they can monitor the progression for you. Like Amit said, Dr. Amit Mohan said that they are using Maya, which has an inbuilt growth curves. So once you have those combined equipments, your cost goes a little bit down. So that is what I was coming to. So ROI basically will come from the glasses only. You can't you can't build a myopia clinic without going to the opticals, because opticals will hold the key when it comes to getting the money out. If you are really into calculating the ROI and building the practice based on how much money you are getting. For a pediatric ophthalmologist, it's like Meenakshi madam said, it's a natural offshoot. So you will get your pediatric patients who would be myopes, who would be hypermetropes. And so people like us who jumped onto myopia mainly because they were into pediatric ophthal, and so they had to, these patients would naturally come to you, not like you have to go and get a separate myopia control clinic for you. So ROI is not that difficult.
So keeping in mind, we need to have a good optical setup as well.
Yes.
So that will be
Dr. Jiten sir, can I just ask a question?
Yeah.
So, sir, like there are many cataract surgeons like me who are neither pediatric ophthalmologists, and we do not have any trained pediatric optometrists. They can do the retinoscopy, but they are not specifically trained for the pediatric patients. So, do you think, like, because when I was listening to the Dr. Riddhi, she mentioned about so many things like convergence, accommodations, peripheral refractions. What are the minimum measurements which has to be documented? And do you feel that a trained pediatric optometrist is must other than the equipments part? As if I talk about the staff, like what all staff are required to start a myopia clinic?
I think if you write them down like 1, 2, 3, 4, 5, 6 and tell the staff to do these things like binocular examination, you can do a quick orthoptic evaluation, you can do a near point of convergence, near point of accommodation, accommodative facility, and cover test. If you can do that, you can do before you start a practice, you can do pupil size, autoref, cycloplegic refraction, axial length, and keratometry. So then you have a fit this, you can make a small, sort of a case sheet where you can write that these things are a must. And if they don't do it, either you have to do it or you have to ask them that, why this has not been done. And then these are, I mean, I'm really cutting down the list. I'm just saying that this is bare minimum. Because this is bare minimum because once you start giving them treatment for myopia, they may come back with imbalances in this, and there is no way for you to know that this was pre-existing or this has started after your treatment. So that is very, very important. You may, these are very small things. These really don't see near point of convergence, near point of accommodation. You can take a RAF ruler and do it. It is not really a pediatric ophthalmic domain. In fact, it is purely into optometry. But these are all very simple things. A cover test or a stereopsis is hardly any technical thing. It's a very pretty simple
So
thing.
if you have a specific template for the myopia patients, then it is better. Like the checklist
Yes,
should be there.
because you can
Okay.
then you can tell your optometrist that these things you have not done, and we have to get these things done. Pupil size, I don't do pupil size a lot, but you need to do it because if you are starting atropine, there is no way for you to know whether pupil is dilated or not.
So
these
if
are
I may quickly add to what
Yes.
if I may
Yes.
quickly add to what you already said, Jitendra,
Yes, sir.
exactly answering your question is, you just need to have a clear protocol. And many of the things in protocol are not rocket science. They're all very simple things. And the optometrists are dedicated, select one or two people. Always have two people. And your myopia clinic shouldn't come to a standstill if one goes on maternity leave. So have two and train them both in all these little gaps. That's all you need. It's not really anything complicated or rocket science. And hopefully myopia clinic and management of myopia is something that we all share. Pediatric ophthalmologists, general ophthalmologists, comprehensive ophthalmologists, everybody shares it. So I just want to reassure that it's not such a big deal, but your protocol should be very clear from patient number one.
And ma'am, manual retinoscopy is mandatory, or we can rely on a good, reliable autoref?
No, cycloplegic retinoscopy, I think, is a good skill, and it's a good, like I said, sometimes when you use home atropine, the cycloplegia is not complete, and the autoref can sometimes give you false values as well. So, and then there will be younger and younger kids who will not cooperate for autoref. We may not all have invested in handheld autoref. So I think it's good to have at least yourself or maybe one or two optometrists well trained in cycloplegic retinoscopy. When in doubt, do atropine refraction, do atropine retinoscopy. When in doubt, then there is
Excellent
no
discussion. So, madam, if we can conclude by saying,
Thank
what
you
do
so
you
much.
think for a small setup? If we start with documentation, do an eggshell length and a cycloplegic refraction, that would be a good baseline. Agreed? Thank you so much. We'll just move on to the next session and maybe take up more questions towards the end.
Yeah, so now we have seen how to plan a clinic, what equipments are needed, but we also need to learn how to optimize the flow of the patients of myopia in a real busy OPD days. So Dr. Prachi Agashe, she will now speak about on patients and workflow optimization in a myopia clinic. Over to you, Dr. Prachi.
Good afternoon. Am I audible and is my screen visible?
Yes, doctor, clear.
Yeah, thank you. So, good afternoon, one and all. And once again, congratulations, Dr. Jitendra and Dr. Namrata Sharma for this fantastic series of myopia modules. I'm probably the last speaker of this module. So I'm going to talk about patients and workflow optimization. A bit of it is going to be probably a repetition of what the two speakers have spoken earlier, but let's see what we can take home from this talk. So we had a discussion about, does it really require a formal name? So based on the discussion that we were having right now in a anterior segment only, you may not in fact even name it, or at least put it in your list of services where you mention the list of services and say that you're offering myopia treatments. Even that is sufficient, even if you're not putting a formal name to it. However, if you are putting a formal name to it, there are certain benefits to a practitioner. One is streamlining of patients, easier on the system. The staff is attuned to attending the patient. So basically, the staff has to be aware that you are doing this treatment. Otherwise, if there is a query at the reception itself, that they will be, they will not be able to answer that. Also, parents can interact with each other, and this mouth-to-mouth interaction is something which is very important to spread the word around. Also, sometimes group counseling can be done. Now, this can be on a particular day, or even if you have 2-3 patients at a time and you want to save on some time, you can talk to the parents together about the general things and then have an individual consultation again. This gives a sense of belonging, and sometimes in the waiting room in the typical Indian cells, it gives a sense of competition. Now, this does act as a good marketing strategy for the clinic generally. So, now, as Dr. Reena had said, that probably when the count of the OPD is about at least 10% of your daily OPD has children with myopia, you can definitely think of designating a myopia clinic and maybe assigning days. As Madam said, it is probably difficult to assign a particular day, but when the volume increases, it is sometimes helpful because then you can assign an optometrist for the same. Now, this is probably true in the institutional setups. In private practice, it may not really be feasible to always name a day, though based on the patient flow, you can think about it. Also, advocacy in various forms, as was said earlier, is by putting up simple posters about the condition, about the things that need to be done, the good activities that the children can inculcate. So this kind of creates a curiosity in the waiting room, because when the parents are waiting for their turn for their workups, they naturally tend to look at the posters around. Newspaper excerpts or running some videos in the clinic is also a very good way of educating the parents. So when they're already reading the stuff and half of the education is done, probably they already have their doubts in mind when they're coming and talking to you. So this could make your job a little bit easier when you're talking to the parents. Using social media and important milestones in the condition like National Myopia Week or International Myopia Day, you can talk and use these days to try and spread education among the masses. Facebook, Instagram is growing more and more, especially the younger parents tend to look up on these sources a lot. So try and put up your educational material on this. Also, a simple thing is the BHVI website that is there. They actually offer free downloadable pamphlets. So in case you don't have the bandwidth to design the stuff, to put up the stuff, these are free downloadable pamphlets, which you can just take a printout of and then can just put it up in the clinic. Then based on the size of the clinic or the size of the hospital, you can again use the optical areas to try and talk about the glasses, their mechanism of actions, and again try and educate the parents about these options that are available. So naturally, when these posters are there in the clinic, whenever the parent comes in and you're talking about the glasses, probably this is the question that they ask: do they need the special lenses that have been advertised outside? So then it again helps in educating the parents about this. And the size does not matter. If you have a small clinic, you can have small posters. If you have a big institute, you can go ahead with bigger and more material. Yes, conducting eye screening camps is a great way of promoting the newer practices. Taking talks for teachers, students, again helps in inculcating good habits and spreading awareness about the newer treatments about it. Now, coming to the actual flow of work, how do we go about it? We profile the patient, work up the patient, and then do the counseling. Now, this flow of work has to be very, very clear with your team, which is what gives you the good results. Because as we know in pediatric patients, the waiting time is always slightly more, considering that every child gets dilated and spends approximately at least 1 to 2 hours in the clinic. So if a part of the workup can be done during that, it is greatly appreciated, and the parent's response at the end of it is much better. So if you are in tune with your team and the optometrist, as we were talking about, and this is a myopia workup sheet that we have, and all of this is recorded in the myopia workup sheet. So which include all the history, the number of myopic parents, the screen time history, the outdoor history, all of that. And then the child is proceeded for this workup. Now, if a known myope who is already on treatment is coming and the duration of follow-up is more than 6 months, then all of these has to be done. So as soon as a child is taken up for a vision refraction test, immediately the child is sent for dilatation. the orthoptic workup is done, the accommodation is also checked, and then the dilatation is done. The peripheral refraction is done, the axial length and keratometry on the biometer is done. And all of this gets recorded in the sheet. So when the parents and the child come to you, you have all of this ready in your hand, and you are ready in your head about the counseling, about what you want to do with the treatment of this child. Now, counseling of the parents is something which is extremely important. Myopia treatment involves a lot of chair time. So be ready with your PowerPoint presentations, your pamphlets about to discuss the options, discuss the pros and cons of the drops, the classes in detail, including the cost factor, discuss the success rate, tell them realistically what is our goal, and never forget to emphasize the importance of lifestyle modifications. As was said by Dr. Reena, showing the myopia calculator, there are various softwares. It drives home further the importance of the treatment options. Now, the conversation with the parents is a 4-step framework. Okay. So this is something which is practically very important. So the first step is be prepared, as I said earlier, with whatever information you want to give them about the condition, about the charges, etc. Second is create curiosity. So did you know we can slow down the myopia? Have you heard about it? So use the biometry report to show them what you're talking about. What is the axial length? What is the keratometry? What you're trying to do when you're trying to speak about the treatment. Read the room. Now, this is something which is very important. Gauge fear versus skepticism. So you would have some parents who are already scared with whatever you are saying. Okay. On the other hand, some set of parents would already be frustrated and angry with the time that they've already spent in the waiting room. And some would probably look at you with some kind of suspicion as to what is this lady talking to you about. So adapt the pitch. Sometimes involve the child in the discussion and read the room. Based on that, you can decide whether you really want to call them up for a follow-up again, or you want to tell them about the treatment then and there and insist about it. If you feel that they are unsure about it, just mention to them that this is the latest treatment, document it in their report, tell them to go back and read and come back, and then we can take an informed decision. Always be available for follow-ups. Many a times once you have talked about this, they would have questions that come up later. So don't completely deny them. Either have a scheduled follow-up or you can have a quick teleconsult about this. So the conversation will have to continue sometimes after the exam, especially the first examination. When you're trying to explain why you want to control myopia by giving certain analogies. Like an eye elongation is akin to stretching a balloon. The retina is thinning out and it becomes prone to tearing. Or the dental analogy, like visual hygiene. Glasses are like filling a cavity, and myopia management is like brushing to prevent it. So basically, we aren't correcting vision for today, but we are trying to protect the eye health for a lifetime. You'll invariably be asked about LASIK. So LASIK is basically correcting or removing the power. But what here we are trying to do is basically restrict the final myopia and the overall eye health risk that is involved with eye myopia. So insist on this point. Value-added services, we discuss about setting up days for the clinic. Even if you are a solo practitioner, you may not have days, but you are still okay to say that you are having a myopia clinic, because as long as you're offering the correct treatment in the correct way, you are running a myopia clinic. Whether you want to talk about it aloud or don't, it depends on a personal level. Distribute pamphlets and circulate videos for information about the condition. You can make customized myopia booklets. The defocus glasses booklets are invariably provided by the companies. Just hand the booklets over to the parents, let them read about it, let them get more informed about it. Distribute toys that can be played outdoors to mirror what you're saying and actually mean what you're saying. We talked about having a trained optometrist and counselors. So Mr. Rahul was talking about the family sharing their concerns. It is very true. Many times they will come up with the minor doubts and minor difficulties with the optometrist or the counselor, but not with you. So having that middle person is always very helpful. Ensure to enter a follow-up date and send reminders for the same. So this is one practice that I would say should be diligently followed. We get a lot of compliments for actually doing doing this, and they appreciate that they have been reminded, because most of the times the follow-up dates are forgotten by the parents and the kids in their busy schedules. Group the patients in a separate Excel. This will help you analyze your own data. You can create a WhatsApp group to put up information, pamphlets, or newer treatments that you're coming across, and also can send updates or offers of the group. So the financial aspect, as Dr. Reena was saying, you can decide it from patient to patient. Make sure that you are putting up your charges in the waiting room itself, so that there is no ill feeling about the charges. Yes, you can create a yearly package, etc., but that would depend on the admin of the group, admin of the hospital, and the way the practice is running. So, all in all, identify the potential to set up the clinic, advocate and market about the facility, assign fixed days for the clinic if feasible, have designated staff as one point contact to clear doubts real time, identify, enroll, workup, and counsel, ensure to maintain a follow-up date and send reminders. Thank you very much.
Thank you, Dr. Prachi, for the wonderful presentation. I have a question for you. You mentioned about group counseling in the starting. So how much it is effective for a group counseling for the myopia patients? Because if you counsel them together about the risk of the myopia progression or how we can stop it, I think they can adapt it more easily. Or do you have...
So I think it's a good thing sometimes. So I do this for retinopathy of prematurity also sometimes. So the basic counseling about the condition, okay, it's a good idea to talk to the parents together about what you're meaning about trying to control myopia, the risk about it, the eye health risk. So it creates a sense of belonging. When 4 groups of parents are getting the same set of talk about a condition, it kind of creates a seriousness about the condition, and they don't feel isolated about it as well. So I feel it's sometimes a good practice. It may not be feasible at every point in time, but as I said, it depends on how your practice is running. I can do that in some centers, I cannot do it in some other centers that I go to, but it is not a bad idea. So you can actually run a PowerPoint presentation about the condition, show them, explain to them, and then have a consultation privately about every child. So the common factors can be discussed, and then the individual treatment can be individualized with the family.
Okay. Thank you, Dr. Prachi.
I think it is also very helpful, when you want to talk about the fact that some child is progressing and some child is not progressing. Because what happens is that it becomes easier to cut down that problem. Otherwise, they, as individuals, they will keep coming back saying that, doctor, you had given these expensive glasses and still this is happening. Some may be on the combination therapy. So it is more like, the kind of support groups, those support groups which they have in Western countries, where, they have support groups for rare diseases, like they have Down syndrome support group, anemia support group. So that way it really helps.
Sir, if I may add something to that, if that's okay.
Please.
So if you see, there is something which is called as a Kubler-Ross grief cycle, and it's a grief for the parent that now their child has a problem in the eye. So it helps them in the bargaining stage that other people also have the same thing like me. So I'm not alone in this room. So it helps in the acceptance of myopia management much better because of that Kubler-Ross grief cycle. And that's how the group things actually works. Thank you, sir, for the opportunity.
I'll just ask.
Go ahead. Please go ahead.
I just wanted to ask, because we're discussing about the group thing, I wanted to ask Deepak sir and Meenakshi madam, how do you balance patient expectation? Like this group counseling now seems to, okay, everybody is there, it is affected, but they have vast years of experience. So how do you balance patient expectation? Because we have biological factors, we have compliance issues. So madam, what is your experience? So what do you think?
So I think channels of communication need to be open with the patient. So when parents are already myopic glasses wearers, it's not such a big deal to convince. Even that they will, some of them will break down and cry and all that will happen. But I think number one is that for them to understand that you're always available for further queries. Number one. So if you are uncomfortable giving your WhatsApp number, give your counselors or your manager's number for them to be able to reach you with queries at all times. So I think that is number one point of counseling. They need to know that the doctor is your champion. The doctor is the champion of your child. and so accessible. I think that is very important communication. The second is that I usually always call them back within a month once, or out of station patients, I will talk to them. I think that again, by the time they would have gone through we heard about the Kubler-Ross stages. It's actually not grief, it's actually death and dying, but it is the same for grief. So denial, bargain, not depression, acceptance. So I think we go through the same stages. Parents go through the same stages for any uncomfortable news. And so I think it gives them a chance to go through some of those stages and come back to you with further queries or questions. Very rarely, if a patient, I think, has to be convinced and they are not, I will give them another patient to talk to. Patient's number, with their permission, of course, but that's very seldom. I think a lot of patients, it's really how you connect with them, and they need to know you're not in a hurry. They need to know you are their champion and that you will have time for them and their queries, however silly or stupid.
Dr. Deepak, sir, if you have any comments on the same, sir.
I think
he's not there. Yeah, he's
no
not
problem.
there.
But I think what happens is that, when you understand that, so patients always, not just for myopia, even for other problems also, like for ROP or pediatric cataract, they always ask that, do you see some patients like this? We have never heard of this. And, when you tell them that there are glasses available, or when you tell them that drops are available, they are pretty surprised that drops are available for stopping the progression. So once they are together, no, it makes a lot of difference. As Madam said, sometimes, they will even ask you, has this been tried by somebody else? And, they do ask for references, but it is much easier when they are present together. So they can just discuss. I think Deepak is back. We can put up the question to him.
Yes, sir.
Yeah, I
So
just
we
had to
were
step out for a
discussing.
second. Apologies.
No problem. So we were just discussing how do you balance patient expectation with our treatment protocols. We are using glasses or the medications, and we have biological and compliance issues in place. How do you balance that?
So I tend to be a little bit. My belief is that it's a losing battle actually, because the screen time is not going to decrease. I mean, if you have kids, you will know half their schoolwork is on screen time. Number two, this outdoor play and all is not going to be there for 2 hours a day. That's all theory. It ain't happening. And even 1 hour is a challenge because they have some other classes, and reaching the class takes time. So their days are quite packed. So while we do tell them all of these information, we think and therefore, because of these reasons, we tend to be a little aggressive with myopia control. So we actually start drops for all kids. We give them this option of the glasses for all children who come show evidence of progression. And if we see a myope for the first time who starts off with a number, let's say, of more than two, let's say two or more than two, we actually start everything, even though we haven't documented progression at our clinic. But there is an indirect evidence of progression from their past records. How do we balance expectations? I just have this routine thing that I say to patients about how number can go up, how we are going to start the drops, what the drops are going to do, what the glasses are going to do. I have a pictorial, I think it's by Hoya, I'm not sure, which very easily can explain what's happening with a regular lens versus a myopia control lens. And then we also let them know that in spite of everything, I keep using the word, it decreases the chances of progression. It doesn't stop progression. And and if there is a length increase in axial length, or if there is power increase, we will increase the drops to twice a day, or we will increase the concentration of the drops. And we tell all of this in the first visit itself. Just to add on another topic, Rupam knows, we tried starting what we would call like a myopia control program, Rupam. We tried doing that, where we offer them so many visits with so many consults, with so much investigation. For some reason, it didn't work in my practice. We see a lot of myopia patients. They are regular with their checkups, but
Yes.
the program didn't work. We stopped doing it. We stopped selling it or kind of promoting it. We are happy seeing our patients and doing what we were anyway doing through the program. We are just not
Yes.
doing it by a program. We are doing it as per consult, and we see them every 6 months for this. So yeah, and some people do ask us, I just saw a patient, how is the power gone up? I'm doing everything that you're doing. So we of course increase the drops. We said it can happen. There could be a genetic component, there could be screen time usage, which is not being controlled. But yeah, I mean, progression is going to happen in spite of everything. However, that being said, I am not like Jitendra and MS Madam. I'm not really an academician. However, we do feel there is significant reduction in kids whose numbers are progressing because of all the steps that all of us are taking.
Thank you, sir. So,
That's
Mr.
why I
Rupam, a quick question. If you have a myopia clinic and you have all the dedicated protocols in place, is there a specific time frame? Because kids may lose patience, and if we have repeated follow-ups for the same, is there a time frame within which the workup should be done or the flow should be done so that the efficiency also increases and the compliance to follow-up increases?
Is that for me?
I asked for you also as well as
Yeah,
Mr.
so for
Rupam.
me, I'll tell you quickly. I think it's true generally. It's not only for myopia patients. Today, everyone wants a good service at any place they visit, whether it's an eye clinic or it's a restaurant. I mean, we don't make our patients wait. So I think that's true for anybody. I don't think that is acceptable to make people wait and then not have a protocol. And so we even have for example, just to give you some context, for example, if a patient comes in for a complete eye checkup, I actually see the patient after the fundus photo. I don't see the patient, then say, oh, would you like to get a fundus photo? Then the patient goes for a fundus photo, then he comes back in the clinic. I feel that has improved patient flow significantly, for example. So there are ways that patient's flow can be improved, but patients cannot be made to wait. Any patient, not only a myopia patient.
Mr. Rupam, do you have a time frame in your clinic setups, the myopia clinics?
Ma'am, the best part is to tell them how long they are supposed to wait
Yeah.
depending on the condition, right? Because if I know how long I have to wait, I have that patience. But if I'm clueless about how long I have to wait, then I get agitated, then I get angry as a patient, right? So probably, depending on the patient's first visit, follow-up visit, just tell them that this is the time that we're going to take because of this procedure that we're going to do for your kid today. Then it becomes much more easier for them. So probably a pre-alignment on the time. And if they say, no, I'm in a hurry today, then we can say, okay, we're skipping this, but you need to take an appointment next week with us as well. So then that helps them to manage that expectation of time. And most of the time I have seen, ma'am, is patients are, they get agitated or angry because they have no clue on how long they have to wait. But if that is told in the beforehand, then it takes, yes, it makes things easier for us that way.
The great
So,
discussion
I
today.
think,
I think
Yeah,
I
I
have
think keeping a fixed day also helps to improve your efficiency because already your staff is tuned. You are seeing the same patients. You can get the same readings done. I mean, the same parameters have to be recorded. So if you keep one particular day for running your myopia clinic, that is very fruitful because it requires a lot of chair time and you can't reduce on that. So I think that helps.
Great discussion today. So whoever is
I think
starting
here is
to...
one.
Yes, sir.
I think there should be also display that the optometrist examination should take 20 minutes. Then the doctor's first examination should takes 5 minutes. Then dilation examination. So if everything is displayed and the total time it will be displayed, then the patient will not be angry, and I think he will cooperate.
Yeah, the efficiency of the system will also improve. Thank you. Thank you, everybody, for
I
joining
have
in.
a question, just a question from the experts. Like when you're planning to go to the next level and you want to dispense the ortho lenses or the dual focus contact lenses, the adopts are there. So do you need to have that lab consultant support only, or you can have it at your own place? Like how do we go for it? Please.
I have an opinion on this because this is Deepak speaking. We just started doing Ortho K about 4 months ago. Of course, marketing, I'll use the word marketing. Marketing is the is everything, unfortunately or fortunately, whatever, and that's how it is. But I don't think it's possible to do without a lab for a regular private practice, because they have to be able to support your optometrists to do the initial trials with OrthoK, which even if you're optometrist, we have optometrists from Lotus College, which is a very good college in Bombay. But if you don't practice it, how are you going to be good at it? And they haven't practiced it since they passed out. They hardly practiced it even when they were in the college, because there are no patients there. So I think it has to be with a lab. For example, what we have done with the lab is we have said we will do, when we do 5 OrthoK trials, we will buy a trial set from you, right? So we have done 4 so far. We have 4 patients so far. And when we do the 5th, we will be buying the trial set from them. So something in a phased manner, some justification for your purchases. But I feel generally with OrthoK, I completely forgot to discuss this earlier. It is used so often in other countries. It's very, very commonly practiced in other countries. In India, we are culturally a conservative people. We do not like to do these kind of things, but the times are changing. We are the parents now. Our kids are needing this. And I feel there is much more acceptance to OrthoK now than it was 15 years ago or 10 years ago.
I think the need also, because now a lot of children are into sports and aesthetics and all this. I think now you really need to have this in your practice.
Yes, I agree.
So, ma'am,
Great.
probably for soft contact lenses, you would not require a lab entirely, but for the specialty fitting, a lab is very much required. And most of the companies who provide specialty fitting also has soft contact lenses in their portfolio, may it be EDOF or a center distance multifocal. So that helps in that entire understanding of our optometrist on how they're fitting the lenses. And I think probably because we discuss contact lenses, I think there is a great paper by Cooper Vision over an 8-year period of study that they have done with parents and child, and how does the child handles the contact lenses and all. That should be very encouraging for the parents, the summary of that study, so that they can choose contact lenses for the kids.
Yeah, we had the author, one of the authors, to speak on that. That was, I think, in the contact lens module. We have Professor Dr. Namrata Sharma with us, and I would like her to speak because this is the last module. I would like her to speak because she has been truly supportive. Actually, completely, it is her thought process that we could do this myopia module in such a short time. And it's such a busy schedule. She has been able to find out time. Please, madam.
Thank you. I think, Jitendra, you are giving the credit to the wrong person, because it is to you that the credit should go to. In such a short time, you were able to actually get all the modules out, do this course, 11 modules, and then to sit through all the 11 modules, design questions for them. And I thought that myopia was such a subject which is very hot right now, and also everybody wants to know. Whenever we have myopia sessions in the conference, they are jam-packed full. And it is every general ophthalmologist's game also. I mean, you don't require a particular specialization for this, but then it is so common that in our country, and now that we are going to even have an epidemic of myopia. So I would like to thank all the speakers, the panelists who've been a part through it. This is the 11th module, and they are going to be certification also going to be done for this. It's going to be there even if people have not attended it now. It is going to be very much there on our AIOS Scientific YouTube, so you can attend at that time and do the questions there and also be certificated for that. Again, the idea is that whatever our ophthalmologists do, they don't go through litigations, etc., for doing something or for not doing something. So that is the basic idea, that is to help. Again, couldn't have happened if Dr. Jitendra Jethani had not taken it up. Single-handedly, I think he took it. And thank you so much, Jitendra, again for doing this. And thanks to all of you for being a part of this myopia journey. And we hope to continue this in some or the other form. So thank you. And again, I think there's so many things which are not taught generally in the syllabus, which were taken up in the course, whether it was orthokeratology or what was being discussed today is something again which everybody is not aware about. So thank you, Jitendra, for doing it, and thanks to all of you for helping with this. I would also like to thank our audiovisual partner in this, Mr. Sunil, who does it on Zoom episode after episode and gets all the logistics in place. So thank you so much. We purposely didn't have a sponsor for this, although we like to sponsor all our webinars because we thought this is coming from AIOS and it should not have a sponsor in it. It should have only the label of AIOS on it. So there were so many people, sponsors who, approached us that you're doing this, we want to do it, but we let it be like that only. It's because we wanted to, not be aligned to any company because there's so many companies making products, for myopia. Anyway, thank you. And thanks again. Kudos to you, Jitendra, for doing this.
Thank you so much, ma'am.
Thank you, ma'am. I think Dr. Deepak wants to make a comment, please, sir, on how
I
to
just
start.
wanted to add a way of how we can start opticals, because as Jitendra very correctly said, that we cannot really consider this is a financially sound clinic unless you have an optical. For an optical shop, you need space. Everyone doesn't have space, but you can always start. And the way one can start an optical is by saying that, sir, you bring your frame to us, we'll fit your lens for you. Okay, we'll fit your lens for you. Rupam can of course help you if you want the Zeiss perspective, but then there is of course there are other companies, Hoya and SLR, basically three companies, and you can start with one person. Okay, and then of course once the flow starts, you have the courage to contact the second guy and the third guy and the fourth guy. But I feel it's very important to start, because then your product becomes viable.
Thank you, sir.
We had a separate module on ortho-K, and there was a separate lecture on MiSight lenses, and the Cooper Vision study was very well discussed. I remember it was by Dr. Card from US. So they discussed it at length about the problem in Indian conditions is that, as Deepak said, ortho-K is a wonderful solution. See, the difference between ortho-K and MiSight soft contact lenses is that, ortho-K, it is the parents who are going to tell the kids to wear it. So they will take care of the hygiene. So hygiene part is out of this thing when it comes to ortho-K, because, parents will make sure that it is hygiene proof and everything is taken care of. And it is in the home, in the controlled atmosphere, that you are using ortho-K. Whereas the soft contact lenses, you are going out, playing, doing things. So there, in Indian scenario, I think it would be a little difficult and challenging for soft contact lenses.
Yes, sir, and
Thank you.
that's why. Sorry, that's why they have all
No, no,
that
no.
daily disposable lenses in the foreign country for their soft contact lenses. Plus, to add to what Dr. Deepak said was that once you start fitting any lenses, if they bring the frame and you fit any lenses over a period of a time, keep a track of the frame that moves the most in your practice, and then you can have a frame inventory yourself as well over a period of time. Because nobody in India or the world has an idea of which frame is going to move in your practice unless and until you have the data yourself. There are no experts in the world about that. So if you are fitting the lenses, it is very good. And probably my last comment would be to thank Dr. Jitendra Jethani and Dr. Namrata ma'am, because I know how many queries I have got, how to get into this course, how to get the certificate out of the course, give me the multiple choice questions, links and all. So this is accepted entirely by most of the ophthalmologists and optometrists in the country, and it has been really helpful to handle the pandemic, the situation we are in. So thanks, Dr. Jitendra Jethani, thanks Namrata ma'am, and thanks AIOS for this amazing 11 module course that we have gone through. Thanks a lot for that.
Thank you, Dr. Jitendra, and everyone. Thank
And
you.
if I could have a quick concluding remark from
please
Jitendra sir, what is the success of a myopia control clinic? How do you define it? Is it stable error? Is it stable axial length? Is it the number of patients or compliance?
I think over a period of time, you do understand that it is definitely, as you said, it is the stable refractive error, but it will never be like, it will be completely stabilized. You can only slow it down. You can't bend physiology completely. You can't stop it. Maybe you can slow it down, and, these patients do come up 2-3 years. There is a small sudden spurt, and then again you think that maybe something should be added. But there's a very wonderful article where they have described that the last year's progression rate does not actually tell you the next year's progression rate. So it's very difficult to predict that, this year he has a growth spurt, and the same growth spurt would continue the next year also. So that makes it even more difficult to move ahead with.
Thank you, sir.
Thank you. Thank you so much, everybody. Thank you so much for, taking out time on the Monday afternoon, which is the heavy day. Thank you, Dr. Stuti and Dr. Nyuti for, taking out time for this particular module. And a big thanks to the three speakers, Dr. Reena, Dr. Prachi, and Dr. Riddhi, for, giving time and in a very short time, because we did not have much time, much timeline. And thank you so much, the experts, Meenakshi Madam, Deepak, Rupam, both Amit and Amit Solanki, all of their very good friends. Madam has been a great mentor to all of us. So thank you so much for being a part of this webinar. And the link of MCQs of this particular webinar is in the chat box. So thank you so much. Looking forward to see you at AIUS. Thank you.
Thank you, Dr. Jethani.